This podcast episode was originally recorded for the Healing Souls podcast and is being refurbished for your enjoyment.
Hello and welcome to the Healing Souls Network. This is Natasha Helfer. And with me, I have Dr. Jim Pfaus. I am so excited to be interviewing him again. I have interviewed him before on subjects of low desire, particularly in female bodies. And yet we here today are going to be talking about a colleague. You know, the field of sex therapy is, I think, fairly new in the history of humanity. So sadly, we're beginning to encounter the death of some of its pioneers. And I really feel it's important to commemorate and honor their work, since I see sexual health as a frontier that's been challenging to prioritize in regards to research, funding, and to educate about its many benefits in regards to all the societal taboos and kind of limitations that many either governments or cultures put that make it difficult for sexologists to go forth in their work. Anyways, I have Dr. Pfaus here with me. If you don't mind, Dr. Pfaus, I'm going to just kind of quickly just introduce you. So
Sure.
Jim, and I'm going to read this kind of from an introduction that I actually really liked about you. So it says, Jim Pfaus has sex on the brain. Woo. An internationally known expert in the neurobiology of sexual behavior. Pfaus has authored over 150 publications and chapters that examine how the brain's neurochemical and neuroanatomical systems are organized for things like sexual arousal, desire, pleasure, and inhibition. These are all fascinating words. We could do a podcast on each one of those words. Anyway, his work focuses on the role played by stimuli associated with sexual reward in priming sexual responses and reveals a strong effect of experience with sexual pleasure on the crystallization of sexual attraction, preference, and performance. His laboratory has also played a major role in the preclinical development of drugs to treat sexual arousal and desire disorders. That's part of what our interview before was about. His research has been reported worldwide in the popular media and has been interviewed for Time, Newsweek, CBC, BBC, ABC's Nightline. His work has also been featured in episodes of the Discovery Channel's Sex Files. And you've been interviewed in several documentaries, including the joint HBO-BBC documentary, Middle Sex. So I think that's all phenomenal. I think you're phenomenal. and I'm also going to lead by just sharing your Facebook post that you shared that caught my attention as to why I'm going to interview you today. So you had posted back in May of 2019, you said, "It is with great sadness that we announce the loss of one of our sexual medicine colleagues, Marcel Waldinger, on May 1st, 2019. Dr. Waldinger was a longtime member of ISWISH, most recently serving on the consensus panel for Persistent Genital Arousal Disorder, also known as PGAD. His landmark work in this area, caring for patients and examining the relationship between PGAD and restless leg syndrome, will be included in the consensus document from this panel. Thus, his work will continue posthumously. Dr. Waldinger will also be remembered for his work in the area of premature ejaculation, helping to develop the content of measuring intravaginal ejaculatory latency time, IELT, used in premature ejaculation clinical trials. He was passionate about his work and about helping his patients, working cooperatively to further knowledge in the field." All right, So there we go.
That was Marcel.
Yes. So I guess I'd like to start by just asking you how you came to be, a colleague of Marcel's, what you know about him and his background, and maybe just your personal relationship with him.
Well, I met him probably in 2004, which at a meeting in Argentina, in Buenos Aires, when the International Society for Sexual Medicine was actually born out of a I guess its precursor society, which was the International Society for the Study of essentially erection and impotence. And it, there was enough of a push for getting women in there, that women's bodies matter sexually. Ooh, imagine that.
That'd be
it's
nice.
Not just all about the penis. So it was there was a movement there, which was kind of interesting, to create a new society out of the old society that would be the International Society for Sexual Medicine. So much more open to the study of, of gender issues, anything, reproduction, anything dealing with sexual medicine and not just the penis and its problem of impotence, which is not even the proper word because impotence meant erectile dysfunction. So even having that term as something meaningful in the name of that organization was kind of ridiculous. And Marcel was one of the prime movers of this because his work was both in men and women. He was interested in obviously erectile dysfunction. He was interested in premature ejaculation. He had done, having met him and realized what a wonderful soul he is, he had done so much work that had been like geared toward understanding how SSRIs, for example, would delay ejaculation. And then, of course, discovering, oh my God, it delays orgasm in women. So, are there connections between women's orgasm and the orgasm that men feel? Are these similar in the spinal cord? Are they similar in the brain? I mean, men, of course, you have an obvious thing called ejaculation, which, if you're going to actually look at substance, can't really be faked. But in women, of course, orgasm can be faked, unfortunately. And that's something that, Marcel was very interested in. When women fake it, is it the same in the brain as when they don't fake it? Like, what is it? So upon knowing him then, I realized this is a person full of depth. He was very well read. I mean, he knew the animal literature, he knew the human literature, which is surprising because most people who know the human literature don't really know the animal literature and probably don't care about the animal literature. But he was very much intent on putting these two things together, realizing that a brain is a brain is a brain of a mammal, and that the sexual systems have been around in evolutionary time since the beginning. And nature loves a keeper. She will keep things that work. And those systems, if I study them in rats and somebody studies them in people, they're kind of the same. Rats do it their way, we do it our way, but it's like the mechanics of that, and certainly the way the brain interprets it, is exactly the same. So finding a kindred spirit in somebody like Marcel Waldinger, for me, was amazing, because here I am as kind of a younger researcher, although Marcel was only like 3 years older than me. But here I was, a younger, quote unquote, researcher, an animal person in a human sea, where people are largely going, rats? Why would you? You can't. Of course, we can study things in rats we can't study in people. And Marcel knew that as well, right? That there are ways of dealing with that. So he had to take what we get, the kind of data we would get in rats, and say, okay, how are we going to study this in people? And so I was struck by this kindred spirit.
That's awesome. And what year was this in Argentina that you met about?
So this was 2004. And then the ISSM, or the International Society for Sexual Medicine, has meetings every 2 years thereafter, which I went to, which Marcel went to. His interest in restless leg syndrome dovetailed very nicely with people's interest in PGAD, because in many women it's synonymous. I mean, they have restless leg, they have PGAD, and putting that together with Marcel was very important in, say, getting Barry Komisarek to come in and say, wait a minute, if those two things are co-occurring, something's probably happening in the spinal cord at this level. And when they started looking, then they found Tarlov cysts, in the spinal cord there, that were putting pressure on nerves that would be activating restless leg and also activating, essentially genital blood flow, unwanted genital blood flow. It's like, holy toot, now we had something to go after. So, it's like a confluence of things coming together. And I mean, Marcel was a huge part of that.
Yeah. Well, I love your thoughts about animal medicine or animal research, because my sexual education with my daughter started that way. She read a book about sexual education with roosters and hens, and at 8 came to tell me all about it. And I was like, And she's like, so is this how humans do it? And I was like, yeah, pretty much. So that's kind of how that went. So you mentioned PGAD. That's not something that a lot of people are very aware of. Are you willing to kind of give us a basic understanding of what that disorder is and how it shows up?
So persistent genital arousal disorder. Now, what do we mean by that? If you find women who, for example, are running to the bathroom every 2 hours to masturbate, are they hypersexual? Do they have some kind of a weird sex addiction sort of problem? No. In fact, they're not doing this to get off. They're doing this to stop the intense engorgement of their genitals. So imagine, if you're walking around with an erect penis all the time, or you're walking around and, you're trying to put that under your leg all the time, it hurts. And especially if the erection is distended. So it's not just having a normal erection, but it's like if you were to take the whole bottle of yohimbine. So you're talking about painful erection. And for women, you could imagine, you're wearing underwear, it's constricting, you're wearing pants that are, a size too small, and this is constricting, and your labia and your clitoris are now engorging with blood, right? And the only way that you've determined how to get rid of that, at least for a small period of time, is to masturbate to orgasm that doesn't feel like an orgasm. It feels like, okay, thank God the blood's beginning to go back into my body. And now you're good for an hour or two. So you can go back to work and do whatever you need to do. And then the engorgement happens again, right? So this is something that Sandra Liebland, for example, first she had patients that were coming to her saying, I'm hypersexual. And she was saying, well, are you enjoying it? And they were saying, no, I hate it. It's awful. I can't stop it. Nothing seems to stop it. It's like, I don't know why it's happening. And she characterized this in 2001 in a paper, and again, subsequently called it PGAD in a paper in 2005. And then subsequent to that, people started saying, well, is it really is it hypersexuality? Is it not? What is it? These women are masturbating. Now, why would you masturbate to get rid of the blood flow? Well, because that's what it does. When you're finished having sex, you've had 50 orgasms, the blood's going to flow back into the system, into the core, right? I mean, that's how erectile tissues work. Blood flows from the core out to the erectile tissues and then back in. And if the clitoris and the penis are, essentially homologous structures, there's no difference between the hemodynamics of the way blood flows into both of those glands. So it's like these women are, many of them had no recourse but to kill themselves. It was so bad. The suicide rate is incredibly high for women who have this. So discovering this and understanding it and trying to figure out what was really going on led to a number of consensus groups getting together at ISWISH, for example, the International Society for the Study of Women's Sexual Health, put together consensus groups that would define it, have it, for example, it's included in the ICD now, which is the European version of our DSM. The DSM hasn't included it, but I bet you DSM-6 or even DSM-5 text revision will, because it's not only got a diagnostic criterion, it also has a diagnostic criterion that we would typically see in the DSM, right, with being distressed about it and having it and understanding what it is. But we understand it from a physiological level now. And for a lot of women, there is nerve irritation. And that nerve irritation comes in the form of what's called a Tarlov cyst. It's a CSF or cerebrospinal fluid filled cyst in this particular part of the spinal cord where sensory nerves that are carrying information from the clitoris. So we're talking about prudental, but it could also be spreading into areas where the hypogastric and the pelvic nerve are coming in, right? So you're getting the entire pelvic floor that is telling the brain, I'm being stimulated. I'm being stimulated. And the brain, of course, responds to that by saying, okay, stimulation, prepare the body for sex. And the way you prepare a woman's body for sex is to increase blood flow to erectile tissues. So nipples, lips, and of course, labia and clitoris. And that blood comes through the vagina. So, if you have a photoplethysmograph in the vagina, you're detecting now the vagina moving closer to the photoplethysmograph as blood is engorging it. And we look at that and we say, okay, that's female sexual arousal. However, the end point of that is to do two things: engorge the clitoris with blood, because what you're doing is you're taking your clitoris, imagine you've got approximately 8,000 sensory receptors in the clitoris, and it's kind of folded in itself, and now it's going to become erect. And what you're doing is you're opening the flower up, essentially, if I can be allegoric, opening the flower up, or metaphor, I guess. You're opening the flower up to reveal these sensory receptors. So instead of them being kind of all shriveled up now they're open to being stimulated, because as blood is flowing in, it's opening that tissue up, just like it does to the glands of the penis. It's exactly the same. So when that's there, that's great. Your body's now prepared. The labia are also engorged, right? And the inner part of the vagina is engorged as well around the mucosa to start mucus secretion, right? Which you need because you're protecting your mucosa against foreign intruders, so the mucus can capture it just like it does in your nose, and B, that produces then a certain level of vaginal wetness, which allows then for a much easier access for a toy or a penis, fingers, or whatever it might be. So imagine then that this is distended.
Mm.
It's not normal, it's distended. And that distension is painful. It is, I mean, you can't sit still.
Yeah.
And that's not the restless legs. That's another nerve that's coming in at the same area that is now being, essentially activated, if you will, by the irritation. So you're telling the brain, and then the rest of the nervous system is now making your legs show this restless leg syndrome. And again, the brain is great at taking that information and saying, okay, this is a normal circumstance, but the feeling isn't normal.
Yeah. It's not based in desire. A lot of
it's not desire, it's not arousal, really. It's something else.
Artificial. And then, a lot of people I don't know understand that female bodies have the same amount of erectile tissue as males do. So that's a lot of engorgement that's happening, maybe not in the same way a penis does it, but within. And like you're saying, all that pressure up against panties and pants. And I've also heard it kind of described as like, imagine always having to sneeze, but you can't quite get to the sneeze, the release of the sneeze. Or even if you do sneeze, immediately you have to sneeze again. Or even kind of the thoughts of urine incontinence where you go to the bathroom, but you still feel like you have to go to the bathroom, 10 minutes, 20 minutes later. And it's never quite this satisfying satiation release that occurs. And this is primarily a disorder that happens in females, correct? If I understand correctly.
Well, I mean, females have been presenting with it, but it turns out we're discovering populations of men who have this as well.
Okay.
And it's not priapism. It's not essential priapism because the dynamics of it are different. They're more like PGAD in women than they are like priapism in men. And you can get priapism from brain lesions. Most men get it because they think, oh, I heard yohimbine will give me a really powerful erection, so I'm going to do the whole bottle because we think linearly as men in Western culture. So the more is better and bigger is better. And this is one case where you really realize there's an inverted U-shaped curve. Bigger and more turgid is not better. It hurts. I don't know if you know the feeling, of course you do, of, when your hand goes to sleep. So it's been resting under something, blood flow's been cut off, and you get that tingling, painful, irritating sensation. Imagine that in your penis.
Yeah.
And that's also what happens in the clitoris and the labia. You get that sensation of this turgid, but it's also turgid. And if you don't shunt the blood out of it in about 4 hours, you're going to start getting gangrene. This is not good. I mean, when you get this, you need to go to a hospital. To take a cold shower is not going to do it. And trying to masturbate, it just hurts. Like there's no way.
Yeah.
When you have this, it's really like that. And for the men who have PGAD, it happens when it happens. I mean, you can be in the middle of a job interview, you can be in the middle of whatever it is, and now boom, you've got this massive erection that is painful. And there's no way to put it between your legs because it's painful.
So I thought that
same kind of thing.
Yeah, I thought the spinal cyst was theoretical. It sounds like you're saying more than that. Like we have found a reason. Is this what you're saying?
It's in most women who have it.
Yeah. Okay. Do we have any treatment?
Oh yeah, removal. It's very easy to remove these. There are surgeons. Chol Kim, for example, is one who works with Barry, and they've been diagnosing these. They've been doing the MRIs to find them. They find exactly where they are. They know how to go in and get rid of them. Now, they may come back. In most women, they don't. And for some women who had PGAD like literally all their lives, right? Now suddenly they're PGAD free, and it's like it's like, oh my God,
wow.
It's revelatory. It's something that really changes their lives because they've lived with it. And of course, some of the women who've lived with it before, we knew exactly what one of the major causes was, they would find amelioration with certain drug treatments, right? So, for example, there are cases where women have been on an anti-smoking treatment, right, in which they would take this, and all of a sudden their PGAD symptom would go away. They go off it. It's got a drug called varenicline. They go off it, and the PGAD symptoms would immediately come back. And that started, me thinking about, well, what's going on here? I mean, I know the systems that are kind of taking information when you have desire, when you're horny, and you see something you like, and you start getting increased vaginal blood flow. Well, I know how that works. Oh my God, might that drug be acting there to start to tell the brain, no, you don't have any more blood flow? And of course, that's exactly how they work. So we're able to get now different levels of the body as to how it analyzes that nerve pressure, that nerve irritation, that then produces the increasing engorgement. But of course, that's a treatment. It's a kind of a, shall we say, a management rather than a real treatment that gets at the root of it. The root of it are these Tarlov cysts. And how would you form a Tarlov cyst? Well, we are a much more athletically inclined group of people now than as women than we used to be, many, many, many years ago. And that it wasn't even true for all women, because of course many of them were athletic and rode horses and got thrown from horses and would land on their backs or land on their buttock that would induce the irritation that would create the cyst. So we have many women in sports.
Due to genetic or biological, they're more trauma induced or some type
seems
of
to be.
theory.
It seems to be. We don't know. We don't have a good indication that PGAD runs in families, for example. Like susceptibility to cancer might run in families. So we have no indication of that yet. But I think there's a very clear evidence that some kind of blunt trauma to the spinal cord, which again, you can compress the spinal cord this way, and you can also hit it that way. So there's no one way that's any better than another. But if you get that there in that lower lumbar, upper sacral part of the cord, chances are you could develop PGAD.
Super interesting. Do you have any statistics? I hate to ask you that just off the fly, but as far as how many, because sometimes I'm like, do I remember statistics off the fly? But just as far as how many people tend to have this type of diagnosis.
I mean, these are beginning to come in at this point, but overall, we are finding anywhere between 0.5% and 5 to 10% who have it in varying degrees, right? So some women have it, and it's really not an issue. Others have it, and they want to kill themselves.
Yeah.
So, there's differential sensitivity to the blood flow, but there's also differential amounts of blood flow that women are getting. A little bit of engorgement all the time might be livable, but horrible distended engorgement that comes and goes at times when you can't predict it and certainly can't control it is very hard to live with. So it's hard to say if the cyst grows, does it put more pressure on and that produces more engorgement? In some women, that seems to be the case. Other women say they've had this forever, right?
Yeah.
And they can remember actually feeling it in the bathtub at age 5. I mean, Irwin Goldstein in San Diego has a case of girls, prepubescent girls who have this, right? And there was trauma. They were soccer players. They got kicked in the back, or somebody, they fell, or they, hit the goalpost, or something happened, where there was blunt trauma to the spinal cord.
Super interesting. Well, thank you for all of that. So that's one area that Marcel was kind of a pioneer in the thought processes of figuring these things out. You mentioned SSRIs, and also, well, I guess even before we go there, it sounds like he was very monumental in defining the parameters of how we're going to think about premature ejaculation. I think is very wise to define those parameters because, again, like you said, in a culture where bigger is better and more is always, I get a lot of men who come in and are like, oh, I'm sure I have premature ejaculation, I'm lasting for only 5 minutes, and I'm like, that does not fit the criteria for premature ejaculation, right? So do you want to talk a little bit about his work in that regard?
I mean, that was some of his, his earliest work was with SSRIs, and we'll talk about that later, but for premature ejaculation, people were coming in saying, okay, well, how did we define it? How did Master and Johnson define it? Not being able to satisfy your partner, not lasting long enough to satisfy your partner. Well, okay, so does that mean that someone who is with someone who has inhibited orgasm or maybe hasn't ever had an orgasm in her life, right?
Mm-hmm.
And there's all sorts of issues about the paint feeling chipping from the ceiling, and who's going to take the kids to soccer, and I'm not in the moment, and I need maybe some mindfulness therapy to liberate my orgasms from all the things I have to do now as a woman.
That's a tall order.
He lasts 20 minutes, but he comes in and says, I don't know, I'm not able to get my partner off. I have premature ejaculation. Like you said, somebody comes in, has lasted 5 minutes, and 5 minutes is kind of a norm intravaginal ejaculation latency. So does he really have premature ejaculation, right? Is it really all relative? Or, Marcel asked, is there some way that we can make an objective, not a subjective, set of criteria for it? Right. So this caused him to do his infamous stopwatch study. The stopwatch study had the partner, whether gay or straight, has the partner take a stopwatch when the penis goes into something, usually the vagina in the case of heterosexual couples, and when he comes or ejaculates, you turn the stopwatch off, and before you're ready to fall asleep, you just jot down the number, how many minutes or seconds actually it stayed in. Okay. Right. So what was the time from the stimulation of the penis in the vagina, not outside the vagina, but in the vagina, to ejaculation? And Marcel took this all over the world. So he has men from almost every country on this planet, not North Korea, but almost every country on this planet, right? And you find that there's a kind of a chi-square distribution, right? So everything is kind of up in the early phase, and then it kind of goes down that way. And the mean and the mode are about 3 to 5 minutes. Right? All that planning, all that poetry, all that music, all those dinner dates to this 3 to 5 minute period of wonderful pleasure. Well,
that's right.
That's where that number comes from. Right? It comes from all over the world. And it's not that one country's better than another. We don't have Italian men can last for, a mode of 7 to 8 minutes, whereas North American men can only last for a mode of 3 to 5. It's like everybody's on top of each other.
That really undoes my fantasies about Italian men. Sorry.
I'm sorry. I'm so sorry. I'm so sorry. I mean, the ones who are into Tantra can last for, a whole weekend. Right. Or so they say. So you can, with that, you can then say, okay, we're going to take a statistical cutoff and say, okay, the ones who are pushed out to, say less than 1 minute, these are the ones who we're going to statistically define as having premature ejaculation. Right. The ones who are lasting more than 20 minutes, in terms of the proportion. So, if we have a 95% confidence interval, we say the 5% out here and the 5% over here are going to have maybe a problem, right? And these ones are premature ejaculators. These ones are delayed ejaculators, right? But then, politics and men's feelings come into this, and you say, well, I'm not premature. I'm just rapid. So, there's been a big fight over whether you call PE or RE. Is it rapid ejaculation? Is it premature? As if there's a mature version of ejaculation, just like, Freud used to call mature orgasms vaginal orgasms and infantile orgasms clitoral orgasms. I mean, what are you really saying? Are you saying that my premature is infantile? I have an infantile ejaculation? Because if that's true, who the hell even knows what infantile means, right? Yeah. So this has been
words matter.
Exactly. Yeah. You don't want to trigger somebody who may. I'm not premature. I'm mature. I'm an adult. But they have certainly, there's certain people still call it PE. Yes. Right. Just like restless leg syndrome was considered a dysesthesia, right? And we've now kind of added that as part of the name of PGAD, because it is a dysesthesia. It's a dysesthesia of the genitals. But, if you say, genital dysesthetic disorder or something like that, it doesn't flow off the tongue nearly as nicely as PGAD flows off the tongue. And it is a persistent genital arousal with dysesthesia. And it can sometimes be paired quite dramatically together. So words do matter, like you say. So he studied this, and he did the same thing in rats. So part of his group was saying, okay, do we have the same kind of, spread? Do some males take a long time? Do some males never ejaculate? Do some ejaculate rapidly? Like, what is it? And it turns out, if you do it in rat time, the curve is exactly the same.
Wow.
So if you take enough rats, watching them have sex, which I get paid to do, if you take enough rats and you do this, you will see that the same kind of distribution exists, right?
Yes.
Which means it's a mammal thing.
Yeah.
Some are rapid, some are not so rapid. Some are really excited and some are not so excited. It just all depends. So you can now statistically define it. And that blew the minds of a lot of clinicians who had been defining it based on the dynamics of the couple and not so much on this more objective statistical notion. And there was a lot of resentment of him doing that. And it's, well, because, you've been defining it for 20 years a certain way.
Right.
And now here comes some upstart, physiologist who's also a psychiatrist and an MD who's saying in his beautiful Dutch, well, I think the way we should be defining it is this way. And it's like, who the hell are you to tell us how to define it? We know how to define it. And, these parts of medicine.
Yeah, professional humility is difficult, right? Like if you're invested in a certain way of thinking about things, that's I think a challenge we all have, which is why I love research. And I actually, I've gotten to the point where I actually welcome when I have to say I'm wrong. I think that's a good personal practice. So
of course it is. I mean, and God knows researchers are always wrong. Right?
Yeah.
I mean, you can't be right about it. Yeah, I hypothesized that this will happen. I went and looked and it doesn't. Oh my God. Well, no, that's a good thing because now you can say, okay, I've ruled out that hypothesis. That's not part of it. Right. And it kind of gets you to a more narrowed focus as to what you need to look at.
Well, and how this was defined before, like you're saying, then would have situational implications. So I have premature ejaculation with Wendy, but I don't have premature ejaculation with Mary, right? And so that doesn't make a lot of sense in regards to from a clinical or biological perspective.
That's right. Well, I mean, it makes you then say, okay, so it's situational.
Yeah.
Right. It's not lifelong. It's not something that you can't control. It actually is something that you're controlling with Mary, but you're not controlling with Cindy because for whatever reason, you're, too excited with Cindy and not all that excited with Mary.
Right.
So, yeah. So Marcel said, look, that makes no sense to me. Right. If somebody comes and says, okay, well, I'm having premature ejaculation with my other partner and not with my wife, what are you doing with that? I mean, do you really have premature ejaculation, or is the novelty of this illicit relationship, being naughty, driving your arousal so high that you are now kind of in sympathetic outflow mode, which means you're going to ejaculate because orgasm is a sympathetic event.
Right.
Exactly. And then,
even comparing from partnership to partnership. So if, John over here, lasts 5 minutes and his wife has an orgasm every 5 minutes with him, but Bob over here is lasting 5 minutes and his wife is never achieving orgasm.
Exactly.
You have similar behaviors and yet very different results. And so
that's exactly right.
Yeah.
Well, and that's the other thing. I mean, there are some women who will have an orgasm instantly.
Mm-hmm.
Now, if they're with a partner who has an orgasm and they'll have like a boygasm in the sense that they will shut down afterwards. It's big. They want to go to sleep. It is what it is. And so if you have that, then what is it really premature ejaculation when he comes at the same time?
Mm-hmm.
You know what I mean? And that's a very, very important thing to consider, because if it isn't, then you're dealing with, trying to uber manipulate a couple's perfectly fine sexual behavior with each other by saying, oh, well, you're not fitting, the proper normative characteristic of what it should be. Mm-hmm. Right? I mean, it's kind of like saying to a couple who have sex, for one weekend a month, that, well, what's your rate of sex? oh, wait, you're having sex less than one time a week? Well, there seems to be a problem here.
Mm-hmm.
But they're having great sex for like a whole weekend in the middle of the month because they live in two different places and that's when they see each other. And they're not cheating on each other. So maybe they're masturbating, but they're not calling that sex. So consequently, you know, we
Mm-hmm.
would say, oh, well, you're not meeting the norm.
Mm-hmm.
And this is why normativeness is so ridiculous. I mean,
Right.
what you enjoy and you enjoy it, and then have somebody tell you, oh, well, you shouldn't be enjoying that because that's not normal.
Right.
It's
Right.
ridiculous. It's ridiculous from a clinical standpoint and from a societal standpoint.
Right. Well,
Yeah.
which is a really interesting dilemma about how we're going to measure distress and where distress comes from.
Yeah,
Right.
for sure.
So if I'm distressed about something for legitimate reasons or culturally imposed reasons, or my doctor told me to be distressed when I wasn't distressed, or, all those things.
No.
So those are very, okay. Well, so that's fascinating. So that was another area. Let's dive into the SSRI stuff. Tell me about that.
So the SSRI stuff was really interesting. And this is what he did is, he got his medical degree. He did work in psychiatry. And then he went back and got a PhD in clinical psychology. So, I mean, this is an amazing guy.
Yeah,
where
that's
he's
pretty fascinating.
where he's doing this work. And so he started to look at the effect of SSRIs on ejaculation latencies, right? And I'm just gonna pop something up here to be able to read you the title of his PhD thesis, which was called When Seconds Count: Selective Serotonin Reuptake Inhibitors and Ejaculation. And what he was doing here, this was the beginning of his stopwatch technique. So he was having partners of men who were taking SSRIs and who had now experienced this delayed ejaculation or anorgasmia, like, because it would be delayed and then they'd lose their erection. They'd just be like, what the hell is going on here? Right? Because I get really close. And then it goes away. And they were freaked out by this. And this is like back in the 1990s, when people didn't even believe that SSRIs produced any effect on sexual behavior, right? So it is now known as the main side effect of most of the very potent SSRIs like fluoxetine or sertraline. And so it was the real thing, but with the stopwatch now, you didn't have somebody coming and saying, it's just not happening. You have somebody coming and saying, yeah, it's delayed by X amount, right? My normal pattern was this, and now it's out into the nether regions. So when seconds count, right, was what he was doing. And he looked at it over time in humans who were just put on SSRIs and in rats who were beginning to take SSRIs, right? And you see the same kind of delay.
Right.
So
and
it's
for
very interesting.
those who maybe aren't super informed, SSRI, can you just give a basic idea of what that means?
These are the antidepressants called the selective serotonin reuptake inhibitors. So, things started out with, monoamine oxidase inhibitors, and then they got more. Western medicine doesn't say, oh, it's more holistic. I like that. They want to go, well, what's the root of the MAO, the monoamine oxidase? That enzyme affects all of these different neurotransmitters. So we're going to get more specific. And so they got reuptake blockers of noradrenaline, or called the tricyclics. And then they got reuptake blockers of serotonin. And those ones seem to make people kind of feel like they're okay all the time, right? So we have the fluoxetine ideal, where you're just kind of happy all the time. So you don't really do much to make yourself happy because you're already happy. And it turns out that's a very important thing, because you don't need to have an orgasm when you are in a state that orgasm produces. So if you think of the refractory period, so you have this mind-blowing orgasm, this release that's related to opioid activation in the brain. That's your reward, that's your pleasure. And then this long-term feeling of satiety, like I'm done, I can go to sleep now, I'm in this happy place. SSRIs produce that effect by blocking serotonin reuptake. They're doing the same thing that your orgasm does, which is producing a massive release of serotonin, right? So once you're in that state, you don't need to do anything to get to that state because you're already there. I mean, essentially, and your brain interprets it that way. So, what happens to sex? Well, you may have desire for sex, but when you actually engage in it, your orgasm is now more and more delayed. And I mean, people have used this now. So some women who have like lots of little ones, when they go on the SSRIs, suddenly they're getting like one big one. But if dude can last for the 15 minutes it takes for her to release that, it's like, oh my God, what was that? I've never had an orgasm like that. So it's actually producing a difference in the pattern, which is something that, still is not written about as it should be. Because some of these women will say, okay, I'm going to, now I can't have an orgasm. So I'm going to go off my antidepressant, maybe get depressed again, but then go on them again. So I can have this 2 to 3 week period where I'm having these mind-blowing boygasms, and then boom, now I'm out here and I can't have an orgasm again. So I'll just go off them, take a drug holiday, and go back to here. And they cycle through this.
Oh, interesting.
Right? Well, it is, except for the fact that if they're now going back to being depressed, it's not a workable treatment, right? And they're kind of manipulating their treatment because they want these big orgasms.
Yeah. Yes, this is not following a medical protocol. You're saying,
no.
Figuring out how to do this.
Not at all. Yeah. So it's an interesting conundrum. And when women feel this way, it's like, well, what doctor what doctor are they going to listen to who says, oh, you really shouldn't be doing that? Because they know better. Right? The women know much better than the doctor does as to what they're doing this for. And they may not even tell the doctor what they're doing it for. There's a lot of embarrassment sometimes about saying, well, I'm doing this because I have a way better orgasm. But it takes a little bit of time to get to that point. I mean, as a culture, we're not ready to talk about sex openly like that, I think, unfortunately.
Well, and I don't know that even in the medical field that orgasm is going to be prioritized over depression, for example, either, right?
Yeah.
And so I think you run into some of those attitudes that even if you do go in and complain like, hey, I feel like I'm having a sexual side effect to some of my medicine, well, but is it treating what you came in for? And that's more important than the sexual side effects that you might be having.
Exactly. So, I mean, I think it's problematic. Hopefully there are going to be better treatments for depression out there than SSRIs, because they not only have that side effect, but I mean, there are other side effects that they have too. And not everybody takes to one particular SSRI. It works for some people. It doesn't work for others. For some, it exacerbates their anxiety. So they go on anti-anxiety meds to treat the anxiety, but then that exacerbates the depression. So, and that can begin to cycle women into almost bipolarity, which is not what you want either.
Right. For sure.
Yeah.
Okay.
So that was another thing that Marcel did. I mean, and he brought people's attention to it. I mean, the thing that Marcel really exemplified for me was his concern. I mean, he's a psychiatrist, remember that. He was incredibly concerned about his patients. He didn't impose on them his ideas about how they should be. He really took what they said, like a clinical psychologist would, took what they said and said, okay, we need to find out about that. I need to understand that from your perspective, not I'm going to tell you because I'm the great medical doctor. I'm going to tell you what your perspective should be. It was really this he was like incredibly patient oriented for a physician, not what I would have expected from a psychiatrist. In fact, when I learned he was a psychiatrist, I was actually quite bowled over. I'm like, what do you mean? You're a clinical psychologist. Yes, I'm that as well, he would say. Right. So he would take from different, again, very, very big grand view. He would take from different parts of medicine and psychiatry and psychology and statistics and all of this together to put a framework together that he could experimentally start to understand what was going on. That's phenomenal.
Yeah.
People like that are very rare.
Well, and like you're saying, the multiple fields of study that he was willing to, engage in, so which I'm sure each one of those fields of study gave him different perspectives. And then
that's right.
It's one thing to be willing to do research. It's another thing to be willing to do research all around the globe. and even like you're saying, this human versus animal, comparison that he was willing to engage. So that's a lot of energy that he's expending in a lot of different ways, showing up in his professional capacity. So that's pretty phenomenal.
But I mean, on the downside, as with many experimentalists, he was really dedicated to his work, and so he could do that 24/7,
Mm-hmm.
which is sometimes not conducive to having a partner. I mean, his wife was 10 years older than him, and he had Trudy, and just just a gorgeous human being. I mean, just somebody who's like alive and wants to experience everything. And the two of them had a very private relationship. I mean, he brought Trudy. I knew Trudy. I mean, he brought Trudy to many, many meetings and stuff like that. And they were lovers. They've been married for years and years and years, and they were lovers, constantly holding each other's hand, groping each other, doing all sorts of things. A little bit of alcohol, it's a great, it's a big generation in there, but they were still acting not like old people. They're acting like young people.
Mm-hmm.
Because for them, everything was new. They would go to different places and it was new,
Well, that's pretty unique too, that you can have such a dedicated professional life and not let that get in the way of your relationships at home. That can be oftentimes a very tricky balance.
But I think Marcel was a bit of a workaholic. Trudy alluded to that sometimes. Oh, well, he's going to go to work, so I'm going to drink. She would say it. It's like, okay, But they clearly had a good understanding, of each other's needs and wants. But again, he was tireless. So unfortunately, having a heart attack is something that ends up.
He's fairly young. Right? I mean, if I remember correctly, he was in his late 60s. Is that correct? So
he was in his mid 60s, actually.
Mid 60s.
So I mean, he was born in 1955. That's crazy. I mean, it's young to have a heart attack, and so that he's doing more than he should be doing, and probably not working out the way he ought to be, and not living sort of a that kind of lifestyle where you're going to balance out your physical needs and your health needs with regard. So I mean, it's just, and the other thing about Marcel is, his parents were Holocaust survivors, and most of his family was killed in the Holocaust.
Oh wow!
So he had a very deep sense of humanity. Really, really interesting guy.
Wow. That is fascinating. So as we close up here, what are your hopes in seeing his work go forward? Like, what are the new things? What are the new questions? What are the theoretical kind of research things that are happening due to his base things? Like, where's it going from here?
Well, there's a new consensus document that is going to be published in the Journal of Sexual Medicine by the ISWISH group on PGAD, and Marcel was a critical factor in that group. I mean, we had actually last year just met at the ISWISH meeting. So Marcel, I mean, we have a picture of the consensus group, and Marcel is there. And he was there in February, March, April, boom, May, he's dead. I mean, it's crazy. It's just crazy, right? To know someone and 2 months later he's dead. I mean, it's a weird thing to consider, but his input was so critical in terms of understanding the dysesthesia aspect of PGAD. In fact, that whole thing is his. I mean, that was one of his major inputs into the document. It's going to be I've never seen a document quite like this. It has neurobiologists, it has psychiatrists, it has psychologists, it has gynecologists, it has neurosurgeons, it has a bunch of people on it who brought their own, kind of like how Marcel thinks. So they brought their own expertise to this to create something that, again, I've never seen before. Better definition, better diagnostic criteria, and treatments. Like all at the same management and treatments, and understanding the different levels of the body, from literally the genitals up to the brain and back. Right. And I've never seen anything quite like this in terms of a clinical document. So it's got recommendations for everything, for diagnosis, for maintenance, for treatment, as well as understanding that somebody who's a physical therapist, somebody who's a clinical psychologist, somebody who's a neurologist is going to be able to read this and go, wow, okay, I get it. Right. And I think this is going to be a very important thing. So going forward, that was one thing that Marcel worked on. He also had a book that was coming out this year on premature ejaculation and looking at its pharmacology, different treatment options for different men. I mean, some of the pharmacology came from him in terms of treatment, right? So you take an SSRI, which is going to delay ejaculation by amping the serotonin. Serotonin in the spinal cord is one of the things that keeps you from ejaculating too rapidly. right? It's part of the inhibition. It's part of the act. When you're activating parasympathetically by holding the blood in the erectile tissues, well, that holding that blood is a serotonergic event. So of course that's another mechanical reason why it's hard to. So he surmised, well, if that control is out of control, what if you put these men on an SSRI? Would it, at least for a time, give them now a normal ejaculation latency? And sure enough, it did, and does. And so it's a treatment of choice, thanks to Marcel. So he's kind of outlined all of that in this book that is coming out posthumously,
So it will come out. I'm glad.
Oh, yeah.
Yes. And this document that you're talking about with this panel, when is that slated to be public?
Probably early next year, I would think, in the Journal of Sexual Medicine.
Okay.
Yeah. Okay. But it's a tour de force. I'm very, very thankful to have been able to work on it with these people and just kind of learn from them, because everybody was learning from everybody else. The neurologist is learning from the psychologist, who's learning from the PT, who's learning from we all learn from each other.
Yes.
And when does that happen? Because normally everybody's like, no, what I say is the right thing. No, what I say is the right thing. And now we have everybody saying, we're going to contribute to this so we can understand it better.
In a multidisciplinary way. That's always usually the best way.
Sure.
So is there anything that I'm not necessarily asking you about that you feel like I'm missing in regards to giving tribute to this person?
I think that it's just reflecting on him and on his sort of clinical and research acumen and how he learned from all of that. He's very much the Renaissance person. In the sense, like in the old sense of a Renaissance man or a Renaissance woman. He's a Renaissance person who really thought about all of these different things with regard to sex. And I think it's very interesting, because we think of Kinsey, he was an entomologist, right? But, there was no information, so he had to go out there and get information. We think of Masters and Johnson, and probably many people there in the audience here have seen the Masters of Sex. And, so it's like, it's all about sex, and we're going to use techniques, but we're going to get at sex. And we think sex research is that, which it is, but it's also the brain. It's also the relationship. It's also the way the culture views sex and sexuality and views your part in that. And are you a part of what the culture tells you to be, or are you outside of the culture doing naughty things that the culture doesn't like, or doing things that the culture thinks indicates that you are mentally deranged? Like we used to think of gay people as being mentally deranged until that got voted out of the DSM, thank God. So there's a confluence of input. Sex is a part of everything. It's not that yes, it's its own thing. When you know nothing, you really need to do that kind of, looking at it. But then you think about it, it's like, when you're horny, right? Kinsey always said nobody died from lack of sex. Because the species needs to do it, or else everybody will die. But it's like, you're not going to die if you never have sex. You may wish you were dead, but you're not going to die. So sex never, like in psychology, it never appeared as part of motivation. Because motivation was, you need to drink and eat and thermoregulate and do all this. So where's sex? Well, you're not going to die, so we're not even going to deal with it, right? So it's like, he was one of these people that really put it together with the rest of the things that we find interesting.
Yeah.
And, thank God, because that serves as an example for others who are going to be coming up and becoming great sex researchers in their time, that are going to understand the role of it in the whole life rather than just it in and of itself. And I think Marcel was an example of someone who was kind of leading the way in that regard.
No, I think you posited that in a lovely way. I think it is interesting how something that we've spent so little time in has such an impact in our quality of lives, and with some of these issues that you're discussing, PGAD, premature ejaculation, delayed ejaculation, and also our perspectives around those things are things that really make a difference in how people feel about themselves, how they feel about their relationships, whether or not they think their marriages are sustainable or not, whether or not, like you said, they think that they're weird or perverse or that there's something wrong with them. And all of those things can lead to things like depression and anxiety. And oh gosh, it's just so interwoven.
Yeah.
And why I try to focus on these topics to help us, kind of educate ourselves, heal from a lot of these kind of misnomers, and then rebuild and reconstruct towards better perspectives. And it sounds like Marcel was all about that, and you're all about that, and the work that you're doing. So thank you so much for sharing so much useful information. I mean, this was really a nice kind of melding of a lot of different ideas and thoughts, and I hope people got a lot of it, even just your anatomical verbiage, given your background. I think it's very useful for people to have to kind of sit and think about what some of these anatomical things that you're describing are happening in their lives without us really understanding our our lubrication and our erections and all these things that are happening on a regular basis, and why that tends to be the case. So,
well, it's been a great pleasure. I'm really thankful that you've had me on your show.
Yeah, thanks for coming on. And the best of you, and I hope our paths cross soon again.
I'm sure they will.
All right, take care.
Okay, take care.
Bye-bye.
Bye-bye.
Where time slows to nature's pace, and there is space there to find yourself in her embrace. Some places should be left alone. No so we can always go to the homeland of the heart. Ten 10,000 years of our human history etched on her canyon walls, alongside Earth's mysteries. Some places should be left alone. So we can always go to the homeland of the heart, to the homeland of the heart. Deep in our cities, we sleep without her stars, yet still her presence sustains us from afar. Some places should be left alone. So we can always go to the homeland of the heart, to the home